They're oftentimes aggressive, angry, violent kind of patients. This is why I did not pursue emergency medicine. Welcome to another episode of Why I Didn't. In this series, we cover a specific specialty, such as emergency medicine, and I tell you why I didn't pursue it. It's a mostly useless series, if I'm being honest. It's the opposite of So You Want to Be on the Medical Insider channel. That series is very objective, comprehensive. We talk to experts in the field and give you a whole overview as to what you can expect of the specialty. And this is the opposite. It's just me talking about my experience and what I liked, what I didn't like. And right off the bat, I'm gonna tell you that EM wasn't even on my radar. It just didn't tickle me in all the right places. So two parts to this video. Number one, what I liked, and number two, what I didn't like. So let's start off with what I did like about emergency medicine. The first thing was variety. There's a lot of variety in emergency medicine compared to many other specialties. There's lots of excitement, it's fast paced, you're saving lives. You don't know what you're gonna get each day you go in. And what I've learned about myself over the years is that I need variety. If I'm doing the same thing day in and day out indefinitely for years on end, then it just loses its magic after some period of time. But because with EM, you don't know what you're gonna get when you walk in. Maybe you have one room that's myocardial infarction, one person's vomiting blood, one person has traumatic injury, one person has altered mental state. It keeps you on your toes. Number two is that there's lots of doing in the field. So if medicine is on one end of the spectrum, you have really deep conversations about disease processes and even a little bit of mental masturbation, then surgery is on the other end. You have a lot of time and attention and craft towards training, with your hands in a very narrow set of pathologies that you're gonna fix. EM is entirely out on its own. So EM requires quick thinking. You need to be comfortable with high acuity situations like codes and traumas and have an affinity for quick and simple procedures. Things like ultrasounds or placing central lines or suturing or inserting chest tubes, and obviously a lot more. You're doing a lot of things in a short period of time, and there's little room for slowing down, which, if you like the fast pace, is a good thing. And also, there's no rounding, hallelujah, thank God. It has a much faster pace than something like IM. So IM is a lot of waiting around, waiting on tests, on lab work, etc. It's like,
let's hurry up and wait.
In a way. EM, on the other hand, is fast paced. Let's make a decision, execute on it, and then get on to the next. And I like that because I'm impatient. Number three is easy dispo. So dispo, short for disposition, refers to patient discharge and disposition when you send a patient out from the hospital once your job is done. So on services like internal medicine is one of the most notorious examples. You can have patients continue to be on the service and be admitted for several days or even weeks simply because you're having issues with discharging them to the right level of care, whether that's a nursing facility or someplace else. It's one of those irritating aspects of the bureaucracy of medicine and healthcare. With EM, you don't really have to deal with that. You generally decide either to admit, then it's no longer your problem, it's now the admitting team's problem, or you discharge. And then sometimes, of course, you can also transfer to an outside hospital at a similar level of care. The fourth thing I like is shift work, and that means you don't have to take work home with you. You clock in, you clock out, and you're done. And this allows you to craft a flexible schedule based on what you want. It's obviously not gonna be the best schedule in residency, but then when you're an attending, you do have more control. However, on the flip side, I have heard from older EM docs that the shift work gets much more challenging when you're older, since you still, you have control of your schedule, but you still can't 100% escape the occasional night shift or the occasional holiday shift when you wanna spend time with your family. But this also means no pager. Yes. Number five are the people and the vibe. So from my experience, EM docs are pretty laid back. They're fun people. They don't forget that life is to be enjoyed and not to be a slave to your work. Whereas with surgical specialties, I feel like work defined who you were. Whereas with EM, there was still obviously this rushed energy, but also a lighter tone to the energy. Like, we should enjoy every moment of this too and not lose sight of the bigger picture. I like that. It was refreshing. Number six is the shorter residency, and it's either 3 years or 4 years depending on the program. So you might not think at your stage in training that the length of residency is that big of a deal until you're in it. So 3 years versus something like 6 or 7 years in your late 20s to early 30s is a big, big difference. Not only in the time you get to enjoy, but also a big difference financially. In terms of paying off your student loans, you can quickly make an attending salary after just a few years, and that attending salary is respectable too in emergency medicine. And finally, number 7 is undifferentiated patients. So in medical school, you're trained to actually begin with a patient whom you know nothing about other than just their chief complaint. So with most other specialties, a patient is going to enter a service with a pre-existing condition and a referral. And the reason I like that is it kind of bothers me when you learn a lot of things and then don't actually use them in your practice. So being able to use what you've learned in medical school, whether that's anatomy or dealing with undifferentiated patients or whatever it is, That to me is satisfying. Okay, now what I did not like about EM. The first is that the bread and butter is just not my jam, pun intended. When I was rotating, I saw lots of abdominal pain, lots of chest pain. The majority seemed to be those kinds of conditions. And occasionally you would have something more noteworthy come in, but it felt like you were seeing lots of less than interesting presentations for the occasional short burst of excitement. And for me, I didn't like that. I didn't like doing the 80 to 90% of monotony for 10 to 20% of the thrills. I want 80% thrills, or at least enjoyment, for 20% monotony. So when the occasional laceration would come in, I was always so excited to fix it, which definitely makes me somewhat of an outlier in EM, right? So the EM residents were happy to hand it off to me, and I took great pride and took a great deal of time making it the best closure ever. It was a win-win-win. So I got to practice my suturing skills, which I took a lot of pride and I enjoyed. The patient got a better closure than if the EM resident or attending closed them quickly and kind of haphazardly. And then the EM resident or attending got to do something else with their time that they preferred. The second thing is that the ED is often abused. And I'm not gonna get into the whole reasons for ED abuse, right? Or the social or political issues surrounding them. But the truth is that the ED is often used in a way that it is not designed for. And this isn't to say that the patients are at fault necessarily, right? It's more a function of the broken system. But when you are an ED physician, when you're an EM doc, it's still frustrating. So one example would be illegal immigrants or uninsured patients using the emergency department as their source of primary care rather than for urgent medical conditions. Another example would be homeless patients feigning medical conditions to secure a roof over their head. And then of course you have drug addicts who are demonstrating drug-seeking behavior to get their fix. And they're oftentimes aggressive, angry, violent kind of patients. That laceration example brings me to the third point, which is that it's a little bit too fast-paced for me. So while I do enjoy that occasional burst of excitement, I also like to be extra meticulous with my work. Now, I'm not saying that EM docs aren't meticulous or don't pay attention to detail. That's not what I'm saying. But the laceration is an example of what I'm talking about. With EM, you feel the pressure of trying to see as many patients as possible above some other considerations. And then also by a function of the work, being the first provider to assess a patient, it's only natural that you occasionally get things wrong. So for example, the differential for chief complaint of arm pain can be extremely varied. Anything from a heart attack to cancer to spinal cord compression to infection and a lot more. And because of the nature of this work, to quickly assess and stabilize and refer out, you're likely to get things wrong more often than in some other specialties. And because of this, EM docs do get heat from other specialists for mismanaging things. And for a lot of people, not a big deal. You don't mind the uncertainty or the imprecision with diagnosis or with management, but that's just not my personality type. Next up is that it's not my kind of procedures. So I knew I loved procedures, but I didn't realize how important the procedure type was. And I do like that EM procedures are fast and they have immediate results, but I don't like that they're on average more straightforward and less complex than something like surgery. And again, that's just my personal preference. And the last reason why I did not like EM is that at the end of the day, when I did peds or adult EM rotations, either in medical school or in residency, I felt very much like I was going to a job. I was clocking in, I was clocking out with my hours. It was more a means to an end, a job to pay the bills. I didn't find myself getting into states of flow or getting completely engrossed as often as with some other fields. And EM has one of the highest rates of burnout, and I knew if I pursued the specialty, I would be part of that statistic. And don't get me wrong, all specialties are gonna have elements you don't like, that is normal. But I do think it's important to find a specialty that makes you feel alive and at least amped up from time to time, or at least as often as possible. All right, guys, and that is why I did not choose emergency medicine. If you disagree with any of my points, let me know with a comment down below. If you want to learn more about EM, check out this video, or check out another video on my Why I Didn't playlist. Much love, and I'll see you guys there.